Hello, this is going to be the first of a two-part series of a presentation about classification principles. The learning objectives of these video lessons are to first understand the various classification systems and their application in spine care, to be able to speak multiple classification languages and translate terminology across systems, to be able to apply classification principles to clinical practice. So why classification in spine care? Well, it's foundational to the primary spine practitioner model because it integrates clinical experience with research evidence. It facilitates the clinical decision-making process and improves clinical efficiency. And it helps to reduce variation in spine care. So let's start with some definitions and terminology. The definition of classification is the act of arranging similar things into groups. Taxonomy, you've probably heard this term, is the science of naming, describing, and classifying things. Essentially, the scientific process of classification is taxonomy. And a phenotype, you've heard this term before too, it's really a combination of genetics and the environment. It's an observable set of physical and psychological traits that are attributable to both genes and environment. So we'll come back to these terms a lot. Honestly, they're all about pattern recognition. Now we have here A, B, and C. These are three different patients who all you're looking at is their pain diagram. And I think all three of us would recognize that there are at least two patterns here. That pattern in the center is very different from the ones to the left and to the right. One might argue there's three patterns here, that the axial pain on the left is one pattern, the widespread pain in the center is another pattern, and the one on the right with radiating pain is another one. Regardless of how we want to talk about these patterns, we all recognize immediately as clinicians, these are three different types of patients, or two presumably. Excuse me. So what are classification systems? They're nothing more than pattern recognition. This is a really interesting graphic that I pulled off the internet in a lecture about artificial intelligence and machine learning, which many of you probably heard about. What they do with machine learning is feed in a bunch of variables into a machine, and the machine starts to look for patterns that sometimes the human mind can't even detect. When we talk about thousands of variables. But if you look at this top row with the green, we start recognizing, well, first of all, they're all green. And a whole bunch of them have this sort of rectangular shape to them. And so we see green and rectangular, that's the pattern. We look at the second row, we see mostly orange, and we start recognizing this facial feature here, which is present in most of these. And so now we have a pattern of a sort of smirky, smiley face in orange. In this bottom row, we see that most of them are yellow, and they have sort of this frowny face that's consistent across most of these. And we say, hey, you know, there's a pattern here. So folks, this is basically what you do in clinical practice every day. And this is what classification is, recognizing clinical patterns that we can use to match up with clinical treatment. Because proper classification informs you of the proper clinical tools to use. If we went back to that picture with the widespread pain all over the place, is that a simple manipulation of L5-S1? I don't think so. But perhaps a simple manipulation of L5-S1 is all that patient A needed, whereas patient C might need a directional preference type exercise, or traction, or something else. So the classification sets the foundation for what clinical tools we're going to use. It's the blueprint to clinical practice management. Now, there are many classification systems out there. The treatment-based classification system was developed here at University of Pittsburgh. I'm one of the co-authors. So obviously, our PSP program is based out of University of Pittsburgh. We tend to use this as our model. Doesn't mean it's the best, but we think that it's a foundational model and many others will fit into it. There's a mechanical diagnosis and treatment classification system, which is the McKenzie system. There's a pathoanatomic-based classification system. There are pain phenotypes, which have been, designated by the International Association for the Study of Pain, IASP. There's a movement system impairment classification, which came out of Shirley Sarman's work at the University of Washington in St. Louis. And then there's the cognitive functional therapy, which is kind of a newer classification system advanced by Peter O'Sullivan, another physical therapist. Now, our treatment-based classification system was published originally in 1995. It's gone through a couple revisions, the most recent being in July of 2016. Now, this is a diagram from that article, and I'm going to split this up. Just right now, notice that at the very top, we have 3 buckets, red, yellow, and green, and that is triage by the first contact provider. That's the first level of classification. Is this patient red, yellow, or green light? If they're red light, it means stop. There's medical problems. Yellow light means proceed with caution. Green light means this patient could probably self-manage. The second level of triage or classification, if you will, of the treatment-based classification are 3 buckets, which we'll talk about in a moment. So let's talk about this first level triage by the first contact healthcare provider. Right, getting back to classification, which is pattern recognition, does this patient have medical comorbidities? Do they have leg pain with progressive neurological deficit? When we start recognizing potential red flags of serious pathology, that's one type of patient they're probably not going to manage as physical therapists or chiropractors until those medical pathologies have been ruled out or managed. On the other side, we have green, self-care management. This is a patient with low psychosocial risk. They predominantly have axial back pain, minor controlled medical comorbidities. This kind of acute patient with low fear avoidance, predominantly axial back pain. Let's face it, folks, a lot of those patients will get better in a couple of weeks without any treatment. So they're amenable to self-management. Those are probably 25%, I would say, of patients, 20, 25%. Less than 5% are red flags. Clearly, the vast majority are going to be in this yellow light category, where they have medium to high psychological distress, or they have low psychological distress, but they have leg pain, and they have minor or controlled medical morbidities. Now, the second level of treatment-based classification places people into 3 categories: symptom modulation, movement control, or functional optimization. And how do we classify these people? Mainly by their symptomatic presentation. The symptom modulation patients are acute. They have high disability. If you use an oswestry, these are people like in their 30s or 40s. Their symptom status is volatile, right? They can be feeling good, can kick it off, and they could be very worse. They could be better. It's volatile, very easily triggered. And their pain levels high to moderate. These are patients with pain levels 5, 6 or higher, typically. Now, the movement control folks are people who have moderate disability. Their oswestry might be 30-ish, high 20s, 30-ish. Their symptom status, they're not as acute. Their symptoms are relatively stable, and it's the disability of their functional inability to do things that they would like to do that drive them into the practice. And their pain now is moderate to low. It's below 5 typically. The functional optimization folks are those who have very low disability, symptoms are controlled, pain's low or absent, 3 or less sometimes. Why are they in? For strength and conditioning related to work-related disability. Potentially, they want to optimize a sport or activity that they're just not able to do quite the level they need to. So that's the treatment-based classification, which are going to go into great detail over the next units 2, 3, and 4 of the PSP program. Let's talk about mechanical diagnosis and therapy for a moment. This is the McKenzie system. It's a system where they use repeated or sustained end range loading movements to determine symptomatic responses and mechanical responses. Looking for distal arm or leg pain that centralizes or central pain that peripheralizes with repeated movement. With the end range loading and repeated movements, the MDT practitioner is also looking for mechanical responses. With repeated movement, is there a reduction in the antalgic list or lateral list? Is there an increase in range of motion? So the symptomatic responses that we look for in the mechanical diagnosis and therapy classification is centralizers and peripheralizers. These are patterns, right? So when the pain is moving up centrally from the periphery, we call that centralization. When it's starting centrally and moving distally, it's peripheralization. And these are used to classify patients based on the pattern of the migration of their pain during repeated movements. Now, the mechanical responses we look for are, is there a direction of benefit and a direction of detriment? The direction of benefit is the direction that with repeated movement will reduce an antalgia or list and will increase active range of motion in a previously obstructed direction. The direction of detriment is with repeated movement, the patient's antalgic list gets worse, and they'll start to actually see a decrease in the active range of motion in the opposite direction. For example, if I did repeated flexion with a patient and they're getting worse, when I try to straighten them up, now they've lost some extension. So these are mechanical responses. Again, it's a form of pattern recognition and classification. Now, the mechanical diagnosis and therapy folks put people into 4 classifications: derangement, dysfunction, postural, and other. And as we'll see, with all these systems, there are strengths and weaknesses. One of the big strengths of the mechanical diagnosis and therapy classification is this derangement classification, which is the most common, by the way. The weakness of the system is that the second most common is other, which is not very helpful. But certainly the derangement syndrome in the mechanical diagnosis and therapy classification system is very, very helpful, and we will go into great detail with that, again, in units 2, 3, and 4 of this program. Now let's talk about a moment about pathoanatomic classification. There are ways, based on systematic review of the literature by Peterson, Laslett, and Joel. This was one of your required readings, folks. There was a systematic review that found that based on the cluster of tests and clinical prediction rules, we can, with pretty good certainty, diagnose these 5 specific conditions. Lumbar spinal stenosis is a great example. You don't even have to do a history to find this pattern, right? It's an older patient, typically over the age of 65, who has trouble walking a certain distance. Their legs start to hurt. If they sit down, it gets better. If they hold a shopping cart, that's called the shopping cart sign, they'll feel better. That's a very classic pattern of lumbar spinal stenosis. So again, pathoanatomic classification is based on these patterns that we see clinically. Now, we know there are some challenges with tissue-specific diagnosis. So the International Association for the Study of Pain has come up with these 3 bulleted types of pain: nociceptive, neuropathic, nociplastic. Now, inflammatory is one type of nociceptive pain. We can have mechanical nociceptive pain, right? For example, I can have an annular tear in my disc, and that's going to be an incredible nociceptive pain generator. If I compress or stretch it, it may hurt or feel better based on mechanical movements, whereas the inflammatory nociceptive is more constant because chemicals are irritating the nociceptors. And we'll talk about this again in great detail during our live course, but nociplastic pain is typically found in chronic patients with what used to be called central sensitization. And at the very extreme end of this, we can have patients who have frank psychopathology that really affects their ability to discern physical pain from emotional pain. These are very difficult patients. But again, these are pain phenotypes based on pain patterns. Now, the box here with the columns and rows kind of shows you the different types of nociceptive, neuropathic, and nociplastic pain. We're going to go into this in great detail again during the live courses. I just wanted to show you here a brief overview of these different categories. Now, there are two other systems that are out there, very common in the physical therapy world. Shirley Sahrmann's movement system impairment classification, where they classify patients based on impaired alignment and movements. And the training here is to induce proper motor control of these impaired movements. Cognitive functional therapy was developed by Peter O'Sullivan within the past 5 or 6 years, and it consists of 3 components. It's heavy on using pain neuroscience education for cognitively retraining the patient about the meaning of their pain. He uses graded exposure and functional movement training to increase physical activity and lifestyle change. Now, there are 2 other, I was going to call them classification systems, but they're not quite classifications. So let me explain what they are. These are the first is the StartBack risk stratification tool, which many of you probably heard about. It's a questionnaire developed in the UK that consists of 9 questions. So it's a very quick questionnaire for the patient to fill out. 9 yes or no questions. It's these 5, number 5, 6, 7, 8, 9, those 5 are used to develop essentially a psychosocial distress score. So the higher the number of agrees or extremely this patient checks off, the higher they are at risk for being a more complicated patient in your practice. Now, those 9 items have a total score and a psychological subscore. That psychological subscore are questions 5 through 9. And this is a highly predictive questionnaire. Compared to patients who score low risk on the StartBack, if they score medium risk, they're a little more than 1.5 times more likely to turn chronic at 6 months. This is based on research of over 5,000 patients in a study we did at the University of Pittsburgh. If they score high risk on the StartBack, they're 2.5 times more likely to turn chronic at 6 months if they're acute. You need to be aware if these patients are medium or high risk because they need to be treated differently. And we will teach you how to treat them differently over the course of these live weekends. So the StartBack puts people into 3 strata, if you will. It's not quite a classification system, but it blends nicely with the other classification systems because, again, it puts people into low, medium, or high risk for chronicity based on 5 key psychological factors. Now, a lot of this gets back to the fundamental of clinical reasoning, which is defined as the sum of the thinking and decision-making processes associated with clinical practice, or the process by which clinicians collect, process, and interpret patient information to develop an action plan. Folks, we classify patients in any of these classification systems by using clinical reasoning. And one of your recommended books was written by Don Murphy. It is called Clinical Reasoning in Spine Care, which the abbreviation is CRISP. So Don has created 3 simple diagnostic questions, right, that you use in your clinical reasoning process in order to classify patients. And the first question, diagnostic question 1, is, does this patient have any serious medical concerns? Is there visceral pathology, a life-threatening illness, neurological deficit? Are there red flags? Number 2, if there aren't red flags, where's the pain coming from? This is classification. Determining where the pain's coming from is very important because it drives your treatment. And number 3, what's happening to this person as a whole that would cause the pain experience to develop in the first place or persist? And that's both physical and psychological factors. Now you're starting to see how things come together here a little bit, right? So in diagnostic question number 3, we would consider start back risk as something that's happening with this person as a whole that might be part of why they develop the pain, or it might cause that pain to persist over time. Also in diagnostic question number 3, we have physical findings such as impaired movement control or weakness, things that we would address in rehabilitative exercise that we know perpetuate a patient's motor dysfunction. So the CRISP and start back both add very important values to classification systems. The CRISP, clinical reasoning in spine pain, is a concise set of 3 essential questions of diagnosis that guide clinical reasoning towards classification and incorporates the whole person aspects of psychological factors and physical factors. The start back is a very simple tool to stratify people on their level of psychosocial distress, and it provides a psychosocial context for classification. So this is the end of part 1 of the classification system. In the next presentation, we will be showing you how to integrate all of these classification systems with the start back and CRISP.